Now this the talk is open for comments or questions or discussions. Any comments or question from the panel or from the audience? Maybe before the question coming, maybe I ask the first questions. I'm interested in your molecular profiling. Have you find any factors actually from the next generation sequencing that can predict whether you can respond to pipette or not responding to pipette? Mark?
So the answer is not yet. So we are now on a large grant looking exactly at that. Not so easy. So we looked at the liquid biopsies based on the mutation profile of peritoneal metastasis. This is not easy.
Yeah.
So you need so it's multifactorial. You have it's good to generate molecular data. It's better to integrate the molecular data into the clinical pathological data. Then you need the follow-up, and then you need training sets. You need validation sets. So it's a huge work, and well, we are working on that. We have a huge database, so we have good hope to make it, but we are not yet so far.
Okay, thanks. I think there's a question from Dr. Alberto Takahashi. He's getting at how do you compare pipette versus laparoscopic pipette for those as a neoadjuvant setting or unresectable diseases?
So there is no study, to my knowledge, comparing PIPAC against laparoscopic HIPEC. There is a study comparing laparoscopic HIPEC without pressure versus laparoscopic HIPEC with pressure in ovarian cancer. And the results of the laparoscopic HIPEC with artificial hydrostatic pressure are better. The pharmacological results are better than after well, without pressure. So what we know from our data, but also from the old literature, it is that increasing the intraperitoneal pressure during application of a drug increased tissue uptake. There is no question. That's well documented. That's what PIPAC is doing, and what's HIPEC is usually not doing. The second point is the aerosol nature. So by definition, an aerosol has a better spatial distribution than a liquid. It does not mean that the aerosol distribution of an aerosol is perfect. And when we compare liquid intraperitoneal chemotherapy versus PIPAC in the preclinical model, this is true in the rodent and in the swine, then the homogeneity of repartition after PIPAC is better than after HIPEC and also better than after catheter-based chemotherapy, but is still not perfect. So in theory, PIPAC is superior to laparoscopic HIPEC as a drug delivery technique. And about the role of hyperthermia, because PIPAC is normothermic and laparoscopic HIPEC is hyperthermic. So so we have evaluated hyperthermic PIPAC against PIPAC using the current technology, and the answer is that the pharmacological results are not better after H-PIPAC versus PIPAC. So it looks like the delta you can reach with hyperthermia is much less than the delta, the incremental improvement that you can achieve with applying electrostatic precipitation as an additional physical dimension to PIPAC. So it's probably more cost-effective to investigate E-PIPAC than H-PIPAC, but this is still very preliminary.
We have here a beautiful talk from Professor Ishigami regarding the interest of paclitaxel, intraperitoneal paclitaxel. Do you have experience or ideas regarding PIPAC using paclitaxel for gastric cancer?
So there is a phase 1 study that was just closed in Ghent under the lead of Wim Selen, showing that, well, they didn't reach the MTD, and so nab-paclitaxel intraperitoneally was very well tolerated by the patients. That's what I can tell you. Everything else so far is hypothetical. There are very clear mechanistic arguments to follow paclitaxel as a drug of choice in this indication, but mechanistic arguments are in the Oxford evidence level, level 5. So we have to be extremely careful.
Okay.
Any comment from Ishigami on this? You think a PIPAC with paclitaxel? What do you think?
I think you know very well. You're performing clinical trials. You have started clinical trial, Jimmy?
Well, not yet. We just finished the animal model, and then now we know we have a dose for human trial, but we are going to start the human trial soon.
Really?
What do you think the theory? You think is there's a potential?
Yeah, I think it may work when PIPAC is given with paclitaxel. Of course, I don't know. I've never performed PIPAC, unfortunately, but I think it may work.
Yeah. That's why we want to try. Thanks, Ishigami. And back to Mark. There are 2 questions from the audience. One from Dr. Shannon Chen. He asking, what do you think the most effective chemo regime for gastric cancer peritoneal metastasis in PIPAC? Mark?
Well, the honest answer is I have no scientific answer to that question. So what we did is based on historical traditions of PIPAC. So I don't know if it's true. I have no idea. It works, probably works, but I don't know if it's the best.
No, I mean,
I have no idea. Probably it is not. I mean, I can say the other way. It is extremely unlikely that having a dream, okay, and starting with a drug X combined with a drug Y at the dose Z, okay, I had found just the best combination and dose. That's highly unlikely. So this is this has now to be evaluated by phase 1 protocol, and as you have seen, there are not only several but many that have been completed or are ongoing, and this is the right way to go forward. We just need to generate clinical evidence.
Yeah, and another Dr. Lee was asking about the potential influence of immunotherapy. What do you think about immunotherapy for peritoneal metastasis?
So what I think is not interesting, what is interesting is the science. So what says the science? The science says that the peritoneal cavity is a highly interesting immunological space. And the reason is that if you look at the embryology, the mesoderm is at the external aspect of the embryo, and then invaginates to form the celoma, so meaning the peritoneal cavity and the pleural cavity. So there are high analogies between the skin of the limb and of the legs and the peritoneum. So the innate immune capacity of the peritoneum is exceptionally high. And this has been used in the history. If you look at the hybridoma, so the industry 20 years ago did nothing else than ejecting the peritoneal cavities of mice and using the mice to generate large quantities of antibodies. So there is let's say an interesting background, and now that's what I can say. So far, well, there was also one intraperitoneal immunotherapy, which was evidence-based by a randomized trial about, I would say, 10 years ago in Germany. This was based on a tri-functional antibody. It was effective or relatively effective in ascites control, but it was not so well tolerated. It was extremely expensive, so the company went bankrupt, and the approval has been taken back. So this therapy is not available anymore. So that's it. Then I can tell you a story, but that's not science. I don't want to make like others, just tell you case reports. And but I got a lady, so 40 years old, with yolk sac tumor, who had everything you can think of, meaning 5 lines of combination chemotherapy, including high-dose chemotherapy, bone marrow transplantation, several surgeries, immunotherapy, immunotherapy at last, therapy as an individual treatment with nivolumab. She was progressing under this therapy. She had ascites, 1.6 liters. She had a very high PCI. It was full of tumor in the abdomen, and was pretty sure she would die in the weeks after the first PIPAC, but she was young, so I treated her once. And when she came back 6 weeks later at laparoscopy, and then on the NMR, she was tumor-free. And now we are 3 years later. She had 7 PIPAC. I think she still had periods of systemic immunotherapy, and she's still no evidence of disease. So there might be an abscorbal effect by inducing an inflammation of the peritoneum. This could create interesting synergies with previous systemic immunotherapy. And now, Jimmy, I think you should follow on that, because you have started a study on that.
Yeah, our study is called a piano trial. It's combination of nivolumab systemically plus pipette with oxaliplatin. And but this is just started. We hope that we can report the results soon. Yeah. Thanks, Marc, for this. Still a lot of questions, but because of time, I think we have to end here. I pass the time to Professor Marc Reymond.
Yes. Sorry for the last question. I've seen a lot of questions regarding PIPAC. You can make a training course if you want to make PIPAC, and you will have the response of what can I do if I make some bowel difficulty during a PIPAC procedure or something like that. Don't worry, you can do that. You can do that with the team of Jimmy. Jimmy is one of the leaders now of the surgery, and it was very an example for us, because he make international study, and he work a lot with a medical oncologist that we have all seen with his weight pain. And they are, when I see them, I see that they are close friends and they are able to work together. And I think this is probably one of the key of the success. And Jimmy, thanks to have the organization of this webinar. And I want to say to everybody that Jimmy win the prize of the ESSPP Peritoneal prize last year's. And I think it was a good idea to give the prize to you, Jimmy, because you make a lot of good things. So thank you again to organize this webinar.
Okay, and thanks, Professor Reymond. Really honored to be that. But